I understood through the translation. I'm very grateful to the organisers for inviting me to come here, and I'm particularly delighted to be debating this with Irving, who's, I think, both a colleague and a friend. So I hope there won't be too much blood spilt over this. I'm a bit worried about the vote, because it's really for me to lose this debate rather than to actually win it, isn't it? Because I think I'm starting from a strong position, and I think all I can do is go down. So if I can keep my position, then I'll have won. That's my hope. I think I'd better give some declarations of interest to start with, given that we're talking about antidepressants. So I have had involvement with some drug companies, not particularly recently, and I suppose I can also declare that I have been involved in non-industry-sponsored guideline development, both with the British Association for Psychopharmacology and for NICE, the health watchdog, as they call it, in Britain. So, as you're all aware, this has become a debate of some heat, and I suppose the aim today is to try and shed some light on what is really rather a noisy debate. It's probably strongest, I suppose, across the other side of the Atlantic in America, but certainly it's also present in the UK, and I'm not sure how much it's a live issue in Turkey. But there are articles like this one that really describe this growing chorus of critics challenging the widespread use of antidepressants and why. And I think you're going to be hearing, if you like, what the concerns are through this debate. What I want to show today is that these critics, instead of engaging in debate about the place of antidepressants, they're really applying prejudice independent of the evidence. So that is my strong belief. And they're misusing evidence by misquoting it, ignoring it, partial misrepresentation, or even misrepresentation. And what I'll be showing you today is that impartial evaluation of the evidence leads to the undeniable recognition that antidepressants are useful, are clinically useful in treating depression. So that is my aim and my purpose today. When we look at what the battleground is about the use of antidepressants, I think we can divide it into two main areas. One is beliefs, and the other is clearly the evidence. And one of the problems with this debate is a lot of it is driven by beliefs which, as I'll be arguing, are misinformed. And in terms of the battleground, we can divide it into moral arguments, philosophical arguments, and in the late meaning of the term, paranoid arguments about the use of antidepressants. And one of the problems that we have, before I go on to that, this is just a recent article by Hugh Middleton and Joanna Moncrief, who in the UK are proponents of the point of view that antidepressants aren't useful. And I just want to illustrate what I mean by these three beliefs. So the moral argument is that, in a sense, by treating people with depression with antidepressants, we're actually doing harm by leading them to the false belief that their well-being is dependent on some chemical balance in the brain, and that they're viewed as not being in control of their depression, that they're prey to some chemical problem in the brain. And that morally is not a good thing. We're not enabling people to help their illness. The philosophical argument really probably goes back to the dualistic idea of mind and brain, and the way it's been put here is the argument that by using antidepressants we're somehow feeding into the idea that depression is a disease of the brain. And I suppose the other side of that the argument would be that it's not a disease of the brain, it's a disease of the mind, and therefore needs to be treated with psychological or social treatments rather than physical treatments. And then I suppose the paranoid argument is simply put here that the reason that they're used is understood as an ideology deliberately maintained by those with a commercial interest. In other words, it's all big pharma's fault. So I suppose that would be the strongest version of the paranoid argument. One of the problems that we have is that I will argue that it's the beliefs that are driving the interpretation of the evidence. Now, as you voted at the beginning, I can see all of you here that you're not swayed by emotion, that you're all rational creatures who are determined to follow the evidence. And I think you'll all agree with me that what we should do is we should have the evidence driving what our beliefs are. So what I'm going to be doing is taking you through the evidence to see how this fits in with these beliefs that attack the use of antidepressants. So if we just think about the data, this is the idea about what is the placebo-controlled data. So the core of this argument is what is the evidence in terms of randomized controlled trials when antidepressants have been compared with placebo. Now, the strongest statement of the evidence against the use of antidepressants is this one, that antidepressants don't work any better than placebo. So let us consider that. I will take my honourable opponent's work here. This is his famous 2008 paper in which hit the media, claiming, and was reported widely as saying that antidepressants don't work. Obviously, he did a lot of different analyses, and what I just want to point out, that if you just look at the straight drug versus placebo, there is a positive effect size of 0.32 of antidepressants working better than placebo. And these are data submitted to the FDA, so including unpublished and unpublished data. Obviously, we'll be debating a little bit later about what this effect size means, but it does look as though even my opponent has to admit that there is a signal for drugs working. At around the same time, there was also an analysis trying to look at how much it might be that publication bias affects the outcome. So this is again data submitted to the FDA, and it looks at looks at the effect sizes of published studies, of those in the FDA database, those unpublished studies, and according to different antidepressants. And all I want to show you is the bottom line, which is that although the published data do show a slightly bigger effect size, even if you take into account all the negative unpublished data, you still end up with a significant benefit to antidepressants, and the effect size is 0.31, exactly the same, or nearly exactly the same as those shown by Professor Kirsch. So although there is some effect of negative studies not being published, even when they're taken into account, the signal still remains. So I think we can conclude from this that even the strongest critics show that there is a demonstrable benefit for antidepressants against placebo, a significant benefit, and this difference is not abolished by taking into account publication bias. In other words, the paranoid argument is, when it's reality checked, does not stand up. But even though we've got rid of that argument, it's always possible to look at a different way of looking at it. And we can now come into the arena of how do you explain these differences. And this is probably more important and more interesting. And so this would be that the difference is explained by enhanced placebo or psychoactive effects acting on rating scale items. So although the measurement is true, what it means is not that antidepressants are any better. It's an artifact in some way of what we've done, or it somehow enhances the placebo effect. So it's not the pharmacology, it's not the drugs that are doing it as such in the way that we believe. And again, taking this article by Middleton and Moncrief, the way they put this is they give two arguments. One is clearly that the psychoactive effects of antidepressants may impact on outcome measures. So this might be, for example, things like improving sleep, things that aren't core to depression. But they also have a slightly strange argument, which is that because antidepressants can have different pharmacology, this somehow means that they're not really antidepressant. And this one seems to me a very strange argument, because, of course, the term antidepressant is purely historical, not an indication of specificity of effect. If you look at other branches of medicine, if you're treating heart failure, you can use drugs from different classes without any problem. And we don't mean that just because this drug is from a different class, it's not really treating the heart failure. So does that mean that because they come from different classes, they really don't work? Of course not. So I think that argument is just, a quick look at that shows that it is a purely fallacious argument. So if we come on to a slightly more interesting question, and this touches on the philosophical argument, that is depression a brain disease? Now, I think the term brain disease is really setting up the argument to liken it to a stroke or something like that. And clearly, I wouldn't go along with that. But if we change the argument to saying, is depression associated with functional changes in the brain being, if you like, the organ of the mind, then I think we have to agree that there are changes in the brain that are related to being depressed. And I just want to show you very briefly here, this is a study by Helen Mayberg from quite a way back now, showing that if you look on the left-hand side, that when depressed patients recover, their cerebral metabolism goes up in the dorsal parts of the brain and goes down in some of the ventral parts of the brain, like the subgenual cingulate. And if you take healthy volunteers and who undergo mood induction, you can show the exact opposite changes in the same parts of the brain with an acute manipulation of mood. In other words, mood is, in some way, a function of the brain. It's a physical effect. So trying to say that depression has nothing to do with the brain is clearly not how we understand how the brain works in modern neuroscience. This argument that antidepressants have a non-specific effect can also be challenged. So this is work from a colleague of mine in Oxford, Catherine Harmer, showing that if you acutely give a dose of citalopram, the antidepressant SSRI, you can show that if you ask people then to recognize face emotions, that you get a specific effect. On this one occasion, acute citalopram increased recognition of happy faces and fearful faces, an acute dose of reboxetine increased recognition of happy faces. So this is a single dose, a single manipulation of a neurotransmitter, presumably using the antidepressant, can show a change in face emotion processing, not a general effect, but a specific emotion processing effect. And we've recently shown that the increase in happiness recognition in the first 2 weeks predicts a 6-week outcome, accounting for about 20% of the variance. So you can see here, this is the improvement in the psychopathology rating scale, and this is the improvement in happy recognition, and that there's a significant correlation, suggesting that this change in emotion processing may in fact be an important part of how antidepressants work within the brain. And if you then do brain imaging, you can show that you can have difference in reaction, in this case in the amygdala. When people look at happy and sad and fearful faces, you can show that giving here chronic doses of citalopram change the balance of how the amygdala reacts to negative versus positive faces. So here you've got a decrease in the response to fear versus happy, and you can see, and it's the same here, that after citalopram the response to fear goes down, the response to happy goes up, showing that you can show brain responses in relation to antidepressant treatment. Again, is the pharmacology important in the established effect of antidepressants? And this is, I think, a well-known study by Pedro Delgado, again over 10 years ago now, where people were treated with fluoxetine, in this case, and once they had improved after the treatment, they were then given tryptophan depletion or a control drink, which was indistinguishable and equally unpleasant if you've ever taken a tryptophan depletion drink. And what you see here is that you have a rapid relapse of depressive symptoms after the tryptophan depletion, but not the control, suggesting an involvement in serotonin in this response to fluoxetine. If you look at those who are treated with dizipramine, you don't get any effects, suggesting it's specific for the 5-HT drug, seem to be working through 5-HT, and there are other data that show that if you have a noradrenergic drug, then if you manipulate the noradrenaline system, you can get a relapse, suggesting that the pharmacology plays an important part. Of relevance, I think, what Irving will be talking about later, if normal volunteers are given a 6-week treatment with fluoxetine, if you then give them tryptophan depletion, you don't get any effect on mood. So it doesn't look like it's a sensitization, if you like. It doesn't look like the antidepressants are doing something that makes you more likely to relapse, but that it's something to do with the improvement from depression. So I think we can interpret this as saying that antidepressants do have emotion-specific effects, and that the antidepressant effect of antidepressants can be reversed by antagonizing their pharmacological effect. So what about the placebo, the size of effect? So in the old days, I used to do some meta-analysis, and this is a meta-analysis I did 10 years ago or so. And if we think about the placebo effect, is it possible that antidepressants have an enhanced placebo effect, that it's all through the effect of placebo that underlies the benefit over placebo? Well, tricyclics have more side effects than SSRIs, more dropouts, but if you compare them head-to-head, there is no significant difference in response rates. If you look at it by subgroup, I did find a small benefit in patients, but if you like, where you'd expect to have the biggest placebo effect, which would be in general practice, if anything, the SSRIs were slightly favoured, which makes it difficult to explain this simply by placebo effects. Joanna Moncrief, who I've already cited, took this head-on, looking at active placebos against versus antidepressants, tricyclics against cholinergic placebos, to see whether you could explain the difference simply by the anticholinergic effect. In other words, if it was just simply a placebo effect, you shouldn't see any benefit for antidepressants. Well, what she found was that antidepressants worked over active placebo with about the same effect size again. So this is looking like a consistent story. It's difficult to explain an enhanced placebo effect when you think about that there's a bit of evidence that certain antidepressants might be a little bit more effective than others. For example, the dual-acting drugs are a little bit more effective than SSRIs. The side effects are much the same. Therefore, any benefit is hard to explain in terms of a placebo effect. Similarly, if you have somebody being treated with an antidepressant who hasn't improved sufficiently, as in these two studies, in this case to nortriptyline, in this case to venlafaxine, and you switch them to either carrying on the same drug, in other words, giving the antidepressant more time to work, or switching them to fluoxetine, or to the combination of fluoxetine and olanzapine, or to olanzapine, you can see that if you switch to olanzapine, which doesn't have antidepressant effects, you in fact get a less good response. And that's in spite of olanzapine being very good for sleep and having side effects. So it's very hard to explain this difference by simply being a difference in placebo effects. And finally, just to sort of put another brick, if you like, in the edifice I'm trying to build of evidence here, there's the evidence related to relapse prevention. And I know that this is something that I think Irving is going to be talking about from a different angle, and it will be interesting to debate it. But as it stands, this is a meta-analysis by John Geddes, and what we see in the top here is the first 12 months after randomization. So these are people who have responded to an antidepressant in open treatment, randomized to placebo or to carrying on the active antidepressant. And what you can see here is in the first 12 months after randomization, there is a large benefit to staying on the antidepressant in terms of relapse prevention. And this is a very large effect. On placebo, there's a 60% relapse rate, and this is cut down to a third, 19%, if you stay on the antidepressant. What happens if you do this later? So you keep people on for 2 years, 3 years, and then you do the relapse prevention, the randomization. Well, what you see is you get exactly the same effect size. The relapse rate has dropped because we know that the longer you stay well, the less likely you are to relapse. But the ratio is exactly the same, 30% to 10%. Now, there's an increasing argument at the moment that maybe what antidepressants do is they actually alter the brain in some way, making it more likely that you will relapse if you stop them. So this is an artifact of antidepressant treatment. I think it's very difficult to explain that the longer you're treated with the antidepressants, you'd expect this relapse rate on placebo to at least be maintained or go up if somehow it was related to being kept on the antidepressant causing damage. So I think this is an argument really that antidepressants have what here is a large effect size. So I hope I've persuaded you that the antidepressant placebo differences cannot be explained simply by an enhanced placebo effect. And accounting for the antidepressant placebo differences in relapse prevention by invoking a placebo effect, I put to you, strains credulity. So this second, slightly weaker argument is also, I would put to you, false. But there's still another way to go. So the next thing is how to judge the size of this effect. So the effects are too small to be important or only apply to a small minority of the most ill. And here I have a quote from my honourable opponent, 2 quotes in fact. So from 2002, so this argument's been going on a little while, even if you do make the assumption that the drug effect is the difference, then it's a very small and questionable clinical value, and most recently it reaches clinical significance only in trials involving the most extremely depressed patients. So in other words, it isn't for most people. And of course, this is a well-known result, and I'm just showing Irving's data here based on severity related to the severity of the mean Hamilton Depression Rating Scale at entry along the bottom here, and this is the improvement in effect size. And you can see that with antidepressants, it's a fairly fixed effect size. With placebo, it looks like this drops the more severe you are. In other words, the more severely depressed, the less likely non-specific benefits are to sort of to help you improve. And his argument here is taking a clinically important effect of 0.5, that this only applies to people with a Hamilton Depression Rating Scale of 27 to 28 or higher. Well, recent data, there have been further data showing individual patient data, which broadly gives the same effect, although the threshold is slightly lower, around 24, 25. It's not the only way of looking at the data, of course. If you look at response rates, and these are data submitted for marketing approval in Sweden and the EU, and this is the biggest study so far with 57 studies, if you look at response rates, you can see that across the range of what you might think of moderate to severe depression, you have a 50% response rate on antidepressants and about a 30% response rate on placebo. And this, although it looks a bit narrow at the lower severity, this isn't a significant difference according to severity. So depending on how you look at response, you can get different answers. So you still seem to get a good 20% difference in response rate with this analysis of the data. And I think we just need to pause a moment to think about what do we mean by severity. Now, what's taken as the severity rating on the Hamilton is this American Psychiatric Association severity rating. But you might be surprised to learn that it's based on a single British study in 59 inpatients from 1982. So it's not very convincingly relevant to today's patients. And here we've got Hamilton, this is what the APA give. And of course, this is what's used for this sort of severe or very severe. Now, of course, this is very useful if you want to make the case that psychological treatments work in severe depression, i.e. around 22, because that, of course, sort of supports your case. However, it's clearly nonsense applied to major depression. The maximum score on the Hamilton is 52, or perhaps 46 if you take out the hypochondriasis elements. So we're talking about severe being only half the score that you can get on this rating scale. And I think most clinicians and most drug studies would judge you to have moderate depression in around the 20 to 25 or 26 range, and severe major depression, possibly 27 or even 28 and higher. And this NICE guidance is misquoted. That if you look at this, where did this come from? Well, it was a focus group, of course. It was people sat around and decided what would be a good number. So it's not based on anything objective. And it's seized on by critics. And, of course, even in the original NICE guidelines, it didn't apply to those who hadn't improved. They suggested that you could get away with a smaller difference, for example, 2 points. But most importantly, when we revised the NICE guidance, we abandoned this because it doesn't really make any sense. And it's arbitrary. And I would argue that it's misused. In other branches of medicine, depending on the clinical outcome, much smaller effect sizes are judged as being very important. So if death is the outcome, this company felt that it could trumpet a number needed to treat of 72 because they were preventing acute coronary episodes. If we look at the outcome for depression, of course, this is the STAR-D study, and this is what happens through different steps. And what you can see is, as depression, perhaps the first treatment, or even so, these patients weren't, naive, if you like. That 80% were recurrent or chronic. Mean number of episodes 6. So these are pretty ill. They are pretty ill people. But what you've got is clearly, but quite typical of both primary and secondary care in the United States. And you can see that after step 4, you've only got about a 15% chance of remission with your fourth step treatment. And interestingly, the step 2, it could be CBT or drugs, and there was no benefit. There was no particular benefit of CBT over drugs. In fact, CBT was a bit slower to work. So it wasn't, so the drugs and the CBT were doing the same thing. Now, you could argue here that actually a 5 or 10% difference in response rate is clinically very important. almost doubling your chance of getting better. And I think if I was that person, I would want to have that chance. And of course, overall, a third of patients didn't remit. So this idea that it only applies to a very small minority of patients where a smaller effect size might be important, I think is not at all true. And of course, we do see very big effect sizes. These patients are chosen because they have repeated episodes. So these are highly recurrent patients, and you get very big effect sizes in preventing relapse if you've got somebody who's very highly likely to relapse. So I think we can say that, yes, the size of effect depends on the patient group, severity, risk of relapse, etc. But that doesn't mean that there isn't a potentially important benefit in a substantial number of people, not just a few people, and that one effect size doesn't fit all. So what we need to do is judge what's a worthwhile effect size for this patient in front of me, rather than some arbitrary threshold. So I think that I would argue strongly that this last argument is false. So if we look at driving our beliefs by evidence, I think it's unethical not to treat people with treatments that are effective, or not to offer them the option of treatments that are effective. I've argued that it is philosophically sound in our current understanding of how the brain works and how depression is related to functioning of the brain. And I think if you reality test the paranoid view, you can see that that is false, although we, of course, have to be careful about marketing. So to conclude, antidepressants are useful in the treatment of depression. That doesn't mean that, like all effective treatments, they don't need to be targeted. So this doesn't mean that everybody, whatever level of depression they have, should receive an antidepressant. But I think the challenge for us now is to move beyond the sterile debate of if antidepressants are useful to predicting more accurately who can benefit, understanding the neuroscience behind the action of antidepressants, and in the end developing better treatments for what is a devastating disorder. So what I ask you to do is to support the motion. Thank you very much.